Thank you for kind introduction. I'm Mizuki Miura, interventional cardiologist from Tokyo. So, at first, I want to say congratulations to Ahmedov and Hachim, and I see the live demonstration and the implantation is very good. Also, I'm very happy to share my experience of tab in tab in Japan. So, this is a very famous study. It's the data of 10-year notion. And we can see it's a randomized control study, TABI or SABA, using the bioprosthesis valve. And this is the result. So the hard endpoint is very similar between the TABI and SABA. Also, you can see the hemodynamic data, and the TABI is better compared with the SABA during 10 years. Also, SVD is better for TABA compared with SABA during the 10 years. So now the number of TABA is increasing compared with SABA. Also, the right hand, you can see the tab in tab and tab in sub is increasing. So I think the tab in tab is very crucial. So I want to share my case. The patient is 84 years of female and she had the heart failure syndrome, NYHA2, and shades typical Japanese body and very small body, and she underwent the CABZ and TAVR. Also, she had the atrial fibrillation and hypertension. So we can see the laboratory data, and the high creatine level is a little bit higher, and NT-proBNP is higher. Also, EKG is atrial fibrillation. So this is the echocardiography data. The ejection fraction is normal, but she has severe aortic stenosis again, and minimum pulmonary leakage. Peak velocity was 4.7, and mean pressure gradient was 4.47. And the patient underwent the transesophageal echocardiography in the previous hospital, and we can see some pulmonary leakage. Also, she underwent coronary angiography. Of course, she already underwent the CABG, and bypass graft is not so bad. So this is the first session of TABI, I mean the previous TABI in 2016. We can check the city, annulus area is around 400, and science through junction and science valve is enough to implant the 23 sapien, and coronary height is not so bad. So in this time, we implant the 23 sapien 3 with nominal volume. And this is a final angiography. It's not so bad. It's uh, the height is good. Also, in this point, we have to check the NSP and CRP. It means the neoscalp brain and coronary brain. Because if we consider tab in tab, the first tab portion is very important. Also, of course, the little tab artery is very important. So we have to check the step by step, and at first we have to analyze the index tab using the Sapiens 23. It's almost shaped round, but we can see the narrowest point. Narrowest point is around 300, and inflow and outflow is expand enough. Also, we have to check the nail scut brain and coronary list brain. So in this point, the top of the index sapiens 3 is very near to the coronary artery. So we have to consider the coronary obstruction after second sapien. So which portion should we implant? So ideal level of neoscat brain is top of commercial top. I mean, we have to implant the sapien in the same portion of the previous sapien 3. But if we consider the coronary obstruction, we should implant a little bit lower. Also, if we consider the ppm, we should implant a little bit higher. But ideal position is the same position because the we have to think of the control of the previous leaflet of sapien. Also, if we implant a little bit lower, it's a risk of pacemaker implantation. So we have to decide the size of second tower. So narrowest point is around 300, but average area is around 340. So to be honest, in Japan, it's available. Sapien 3 is available only for the tubing tab, so we cannot use it Everett for tubing tab. So we have to use the Sapien 3, and we have to decide the size. I think 23 is a little bit bigger in this anatomy. Also, we are very afraid of the not so full expand if you use the Sapiens 323. So we decide to implant a 20 Sapiens 3 regia plus 1 cc more. Of course, we have to check the coronary obstruction, the risk of coronary obstruction. If we implant the 20 Sapien, I think it's not so bad, but the uh, Butcher barb to coronary artery, I mean Butcher barb to the right coronary artery, it's very near. It's 1.4 millimeter. So we are very afraid of the coronary obstruction in the right coronary artery. So we decide to perform coronary protection in the right coronary artery using the wire. Access is not so bad. So this is the summary. The 84 years female, severe aortic prostatic stenosis, and potentially risk of coronary obstruction in the right side. Echography, we can see the normal ejection fraction, peak velocity is 4.7, STS very high, it's 16%. So our plan, we 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 will do the transfemoral tapping tab using the Sapiens Regia 20 millimeter plus 1 cc. But we need the predilatation because in the case of tapping tab, sometimes it's very difficult to cross the valve in the previous Sapiens 3. So we always perform the predilatation if we do the tapping tab. So this is the orthography in the tapping tab session. First, we do the coronary protection using the wire in the right coronary artery, and we perform the predilatation using the 80 millimeter balloon. And then we try to implant the 20 sapiens 3 with the regia plus 1 cc more. I want to check the top of the 20 sapiens 3 because I want to implant the same position. And we perform the post-dilatation because we are afraid of the ppm. So fortunately, the patient cannot get coronary obstruction in the right coronary artery. It's very good flow. And we check the final arterography. It's very nice. This is the echography after tapping tab. Ejection fraction is normal, and mean pressure gradient is 4. It's very good. EOA index is 1.9. No PBR, no conduction disturbance, and discharge on foot 10 days after tapping tab. So patient is very fine. In summary, tapping tab can be viable treatment option for THP degeneration. Suboptimal index THP position can make unique challenge for tapping tab. So procedure planning requires through understanding of anatomy and device characteristics. So this is an intraannular device. I mean, the Sapien is an intraannular device, so it's easy to manage the coronary obstruction. But if the previous uh, TAVI valve is like evolute navita, we have to consider the sometimes the basilica and as a procedure mitigate against catastrophic complication, including coronary obstruction, is very important. Adapt and interactive approach to procedure risk management is very important. Thank you for attention.